am really pleased to be able to be here to tell you a little bit about a very interesting application that is used to really view American healthcare and to get insights into American healthcare that can further research. And this is a result, it's an innovation that has occurred at a place called Optum Labs that I'm going to begin by putting into context by telling you a bit about. So Optum Labs is a unique data collaborative that intends to improve patient care and patient value by bringing together stakeholders from around the healthcare ecosystem and giving them access to the largest healthcare database that's available in a collaborative fashion. In the context of who we are a part of Optum, and Optum is a part of United Health Group, which you probably are familiar with. United Health Group is composed of United Healthcare and Optum. And Optum is an integrated health and technology, information technology and health services business that has 80,000 global experts who are making the healthcare system work for everyone. The focus of Optum is on transforming healthcare by engaging the consumer and patient, aligning the delivery of care, and improving and modernizing the infrastructure that makes up the healthcare system. And you can see that Optum impacts 62 million, 1 in 5 Americans, 80,000 provider groups, 5,000 hospitals, health plans, employers, the government, et cetera. But what I'm going to focus on today is Optum Labs, and again, this application that's developed out of Optum Labs, which we call a community health measures platform. So Optum Labs is about 2 years old. It was started by Mayo Clinic and Optum initially. We now have about 20 partners, including AARP and Pfizer, Merck, Boston Scientific, Harvard School of Health, Harvard Health Policy, et cetera. And the focus of Optum Labs is research, translation, and innovation. We, again, are bringing together collaboratives to work in these areas together, and our assets are 149 million lives of claims data over a 20-year period, 37 million clinical lives that come from Humedica, and that's growing substantially, and that's electronic health record lives, which typically have a 5 to 7 year longevity. We also convene forums which enable collaboration. We have partners in translation, some of them being the AMGA, Mayo Clinic, and Optum itself. And we have many experts on the staff of Optum Labs, of Optum, within our partners and alongside Optum, who work together to do this research, to do the translation and innovation. But what I want to show you today is a data visualization power tool that we have developed at Optum Labs that's one example of the way that you work with big data. And we're going to tell you a little bit of a story about healthcare as I show you this. So, first thing you need to know is that this is an exploratory data application. You're going to see some things which may look like conclusions. These are hypothesis generating. This provides an opportunity to understand the data, not an opportunity to draw conclusions. You also have to know that red, in most cases, except for demographics, stands for something that is on the bad side, and blue stands for something that is on the good side of whatever variable we're looking at. So what we've put together is we actually have, for 306 communities across the country, which are called hospital referral regions, we have data on about 100 variables, and those variables are composed of the inputs to healthcare and the outcomes of healthcare. So the inputs of healthcare include such things as economic performance, health behaviors, health IT usage, incentives, population health, social capital, supply, et cetera. You can see that some of these, and each one of these has a bunch of variables underneath it. These variables are both represent things that are about the community itself and also about the delivery of care in that community. And the outcomes of care which include things like adherence to clinical guidelines, utilization and avoidable utilization, commercial medical costs, Medicare costs, disease prevalence, Medicare readmissions, et cetera. But let's start by exploring diabetes. We're going to spend our time in diabetes today, and specifically, we're going to be looking at the occurrence of diabetes in the United States. And what you'll see is a common pattern that the severity of diabetes is really quite prominent in the South, and it's much less in the North and Northwest. Also some areas here around California. And you might see that there's a little bit in this area as well. And so I'm going to go down here just for a moment, take a little bit of a detour, and look at New York State. And you can see that the Manhattan and Long Island, et cetera, have quite red, which means they're in the lowest percentile, which is the worst percentile in terms of diabetes. And if we wanted to, we could add New Jersey, for example, and Connecticut, and Massachusetts. And you start to begin to see that there is really this red hotspot area in New York. But we're going to really focus on a national map at this point. And then what we can look at, instead of looking at all 306, we can just focus in and look at the top 25. These are the best 25 areas in the country. If we want to, we can switch to unfavorable, and these are the worst 25 areas of the country. And a very interesting pattern, again, in the South and in Texas. You can look at a data table, and you'll see Harlingen and McAllen, Texas, which Atul Gawande made famous in his New Yorker article, which perhaps isn't a surprise. But what we're going to do right now is I'm just going to grab those particular areas so that we can look at them for a variety of other things. And we're going to start by looking at a heat map. And this heat map shows the distribution. This uses machine learning. It looks at the distribution of a variety of diseases in these particular areas. These are the worst areas for diabetes. But you'll see they split into two basic areas. One, which is focused in the South, that is not good for depression, migraine, lower back pain, and all the other diseases, but especially around the cardiovascular diseases like congestive heart failure, hypertension, end-stage renal disease. And then another group that's very different, which is mostly in Texas, which has pretty good depression, migraine, and low back pain, and not so bad cardiovascular diseases with the exception of diabetes. So two very interesting patterns that are brought out by specifically looking at the data. And if we want to, we can also take a look at the map, and using these particular diseases, let's look at some of the things that might be correlated with it. And specifically, I'm going to look at obesity. So this is a health behavior, obesity. And we'll go here, and we'll see in these places, obesity, which you would assume was really associated with diabetes, is it's not good, especially in the South, not as bad in Texas. It's in the 40th and 50th percentile. And in other places, it's not so bad. So what else could be associated with diabetes? And I think if you think about it, perhaps health literacy, which we measure in a survey that we do. And again, these variables come from many, many different sources. Some published, others that we collect specifically. And you can see health literacy is pretty significantly associated with diabetes. So we're going to examine this in a more detailed way. This is the graduate course, if you will. We're going to look at all 306 of these HRRs. We're going to clear the names of these at this point. And I'm going to go to relationships. So now I'm going to pick I've got health literacy indicated here, and I'm going to go to outcomes, and I'm going to pick diabetes. And we're going to see something very interesting, which is a nice association between diabetes and health literacy, which is the worse your health literacy is, the more likely you are to have diabetes, or the prevalence of diabetes in your population. And what we can do is, for all 90 or so of these variables, we're actually able to risk adjust with them. So I'm going to risk adjust because I know with high school graduation, whether you graduated from high school or not, the percentage of people who graduated from high school. And what you see is this association that was obvious here has all but disappeared. And this is very significant, because what it's saying is that the effect of health literacy basically disappears when you risk adjust, when you're looking at the same level of high school graduation, which is fascinating. And I'm going to close by taking a look at one other disease, one non-cardiovascular disease, one of the ones that was different that you saw, and that's depression. And you get a very different pattern, which is the more health literacy you have, the more likely you are to be depressed. And in fact, this, again, this is not a conclusion. This is basically an association of communities with disease and level of health literacy. And when you risk adjust for high school graduation, you actually don't lose very much at all. So it suggests that the risk that high school graduation, that there is something different about health literacy that is related to depression, that is different than just simply a high school graduation phenomenon. So with that, I'm going to stop, and thank you very much for your attention. I hope it was interesting for you.